So this first session, we're going to talk about a practical approach to endometrial pathology. And just by show of hands, did you all get a chance to look at the slides? It's okay if you haven't. Anybody look at the slides? Okay, you're just like the residents, aren't you? You can't get you to look at the slides. Just teasing. All right, so then I'm going to take you through all the slides, and we'll spend a little bit of time sort of talking about the pathology. All right, so the first case was that of a 35-year-old with irregular prolonged bleeding for 2 years. And really the point about the first couple of cases was really to talk to you about the distinction between benign changes in the endometrium due to excess hormonal effect, so hyperplasias, if you will, from precancerous changes, which still carry the term hyperplasia, right? Atypical hyperplasia is applied to precancerous changes of the endometrium, but it's a very different disease biologically, right? So if a patient has too much estrogen, and this could be from around menopause, or it could be due to stromal hyperplasia of the ovaries, or she might have a granulosa cell tumor, or she may have too much excess adipose tissue, whatever leads to that excess estrogen, that is a normal endometrium responding to an abnormal hormonal environment. And there's very specific changes that happen in the endometrium that's really a spectrum of changes, and I'm going to show you some of that now. And that's very different from a precancerous change, which is a clonal sort of neoplasm. And in general, those start locally within the endometrium. They can overtake the entire compartment for sure, but they have a very different look to the background endometrium, and that's how you can recognize it. And many times it has associated altered differentiation states like mucinous or squamous and morular change, and we're going to talk a little bit more about morels as well. But this first case really was to just sort of introduce the concept of benign changes secondary to hormonal effect. And I think this is rather an easy case. You can see that it's multiple fragments of tissue that if you go down and you kind of wander around, it doesn't really look like there are extra glands or an increased number of glands. But what you do notice is that there's starting to be cysts, right, throughout this endometrium. And one of the very first changes that you'll see in the endometrium that's seen too much estrogen, this kind of looks like two eyes and a big nose, doesn't it? Is you'll see proliferation, mitoses, and then you'll start to see cystification of the glands. And we think of this as a disordered proliferative or persistent proliferative endometrium. And one thing to keep in mind is that even though we think about disordered proliferative as showing mitoses, it depends on what the estrogen level is at that time. So the estrogen can affect the endometrium, cause it to proliferate and form cystic glands, but then if the estrogen levels decline, you may not see mitoses, but it still shows that it has that background of too much estrogen effect on the endometrium. And this can be due to the stuttering effects of estrogen around the perimenopausal period. And so you might have an inactive endometrium with cystic glands, but you can still imply that there was too much estrogen in that endometrium. So this is, I think, a pretty easy